Thank you, Bob. Thank you, everyone, for hanging in there on a beautiful Saturday afternoon. And thank you for whoever raised the monitor. That's like groovy. Cool. All right, so I have 15 minutes to tell you all about how to induce and maintain remission in inflammatory bowel disease. So you could blow off the rest of the meeting and just do this 15 minutes and you're done. My disclosures. Okay, so I don't believe we've shown this slide, and we have seen the Markowitz study. We haven't seen this. These are the two slides you have to see in the IBD forum. So we all recognize that the pathogenesis of IBD has to do with genetic pre-programming, susceptibility through susceptibility genes, and then an altered response between our immune system and all those bugs that live in our gut. And it's scary but true. We all recognize that there's more and more IBD, and it seems to be happening younger and worser than ever before. So this is to impress upon us the fact that we talk about two diseases, Crohn's and ulcerative colitis, and it just can't be. If you have over 180 susceptibility genes and therefore numerous pathways leading to this final common clinical picture of unrelenting inflammation in the bowel, there must be different diseases that we're talking about. And I think it helps to think of diabetes as the model. If we all called what we see diabetes, meaning there's an elevated blood sugar, we would be treating type 1 like type 2. We'd be confusing our patients, not to mention confusing ourselves. And perhaps until we change the nomenclature and come up with something very creative like IBD 1, 2, 3, 4, 5, we'll forever be talking about how you take care of Crohn's disease, how do you take care of ulcerative colitis, as if they're two distinct diseases, and that's the whole story. And hopefully by the end of this weekend, we all can agree it's much more complicated than that. Whereas my good buddy Jeff Himes always says, it was so easy 20 years ago when we knew everything. So this is a slide taken out of the thought process behind the risk trial, which we recognize as a CCCFA-funded multi-center North American study looking at translationally at newly diagnosed children with inflammatory bowel disease to come up with a tool so we can risk stratify our patients from day one so we know what kind of IBD you have and tailor the therapy appropriately. So I'd like to hone in on perhaps some therapeutic themes. If we're talking about the induction and maintenance of remission in inflammatory bowel disease, there are really some themes that I'd like to highlight. First and foremost is correct diagnosis. I think it's impressing all of us more and more that if we get to the Holy Grail, if we get to that day, I diagnose you, I put you on an effective therapy, and you never have any problems ever again, is that because you never had inflammatory bowel disease, or is that because I'm that good? And we recognize that when we go back to medical school, when you wanted to see inflammation, or your professor wanted to show you inflammation or a plasma cell, they probably showed you a biopsy from the bowel. There's always inflammatory activity in the bowel. It's one of the three places we interact with the outside world. And of the three, it's certainly the dirtiest, right? It contains stuff that starts with S and ends with T. And so we need an inflammatory process there. And where's the upper limit of normal and the lower limit of abnormal sometimes gets very tricky. So I think all of us, if we were honest, have probably diagnosed a child with inflammatory bowel disease, only later to realize they really did not have chronic inflammation, but it was just that isolated, self-limited colitis that we overcalled, and we need to be very careful and very sure. So there's the issues of phenotyping, and we'll certainly talk about that, but I'd like to highlight, let's really be sure that we diagnose the child correctly before we put them on long-term immunosuppressive therapy. We also now recognize that we have an ever-growing armamentarium, thank God, and we can differentiate between induction therapies, those that work quickly, and maintenance therapies, those that perhaps work quickly and durably, or even those that take a little bit of time of onset and then maintain the patient. So induction therapies such as steroids, anti-TNF therapies, somewhere in between I think is methotrexate, and then the therapies that take longer to work such as the thiopurines and now vedolizumab. We also used to think about this fakakta pyramid, which I never knew what that was. It was wider at the bottom and more narrow at the top, but you had more agents at the top than you did at the bottom, and it never made any sense, and that's because it was probably wrong, right? We recognize there's no such thing as step up or step down. What we'd really like to do is risk stratify our patients and step in and give them the right therapy from day one. And as Athos so beautifully just outlined, and you'll hear again and again and over in a repetitive manner at meetings like this, optimizing therapy through strategies such as treating to target and therapeutic drug monitoring is our best ways to use our therapies the best way. What perhaps we don't talk about enough at forums like this is treating the whole patient. And I think that a holistic approach to our patient care is perhaps the part that we think about but maybe don't talk about enough. And the data, what's the data for that? It's been staring at us right in the face. Like anything that's the most obvious, we tend to overlook it. So here's just a busy slide, and what's highlighted is the drug response in the typical biologic slides that we're all used to. What we always seem to ignore is what's in the purple, which is the placebo response, which is actually pretty good, right? You have drugs that are now approved with response rates of like 17%. But somehow, when you do a drug trial, the placebo rates can be up to 40%. What is that? So 40% of the patients get better just because they're in a clinical trial. I start to feel better because someone is taking care of me and actually paying attention to me. So what if we leverage that placebo response? Now, does that actually cause mucosal healing? Does that actually cause improvement of the inflammatory response? I don't know. Maybe that's a little bit overthinking. But certainly it will, if we think about the holistic care of our patients and the psychosocial wellness of our patients, we won't be driven to treat and go on to all sorts of iatrogenosis and therapeutic folly, taking care of symptoms that are actually due to their stress of their disease as opposed to the inflammation of their disease. So I would suggest that psychosocial wellness and psychosocial care of the patient is perhaps the best combination therapy we have in our armamentarium. If we take care of the inflammation and the patient as a whole, we'll probably get our best outcomes. And I'd like to just highlight, I'm obsessed with the way we talk, and I think the way we speak to our patients is perhaps the beginning of their psychosocial wellness. So we talk about patients who failed steroids, and I don't know any patient who ever failed steroids. I do know patients who were failed by steroids. And I think if we talk that way, it makes a lot more sense both to us and how we think about our patients. We also talk about loss of response. That's another one that if you have a patient on biologic therapy and they start to have symptoms, calling it loss of response, you've already clicked into the diagnosis. You think it's loss of response to the therapy and you may change your therapy. Really what they're having is GIST, right? They're having GI symptoms on therapy. And we need to start thinking of it perhaps that way. So the charge I had was to talk about how the PROTECT trial and the findings from the PROTECT trial will influence your therapy. So this is the slide, guys, because there is no results yet. So that was an easy charge. But I will outline a little bit of actually what we have learned. The reason there's no results yet is that enrollment is almost complete and the data is locked. We're not allowed to look at the outcomes yet. So therefore, it's fully blinded as all the patients are enrolled. So for those who perhaps are in the adult side of things in the audience, so PROTECT is a very exciting NIH-funded translational project where we're taking newly diagnosed kids with ulcerative colitis at 30 North American centers and putting on standardized therapy. So by the translational component, just like in the risk trial on the Crohn side, here we'll perhaps have markers for risk stratification in ulcerative colitis, and at the same time look at the best therapy that we give today and what are the outcomes for that. So just looking at the enrollment to date, what have we learned from the PROTECT trial? So I think most of us think about the fact that probably about 80% of patients with ulcerative colitis have pancolitis. And what we're finding in the PROTECT trial is if you look not just at macroscopic disease, but at microscopic disease, it's closer to 90% have the entire colon involved, certainly at the microscopic level as well as macroscopic. If we talked before about the importance of correct diagnosis. What about correct phenotype? So a couple interesting trends are emerging from the diagnosis of kids with ulcerative colitis. 8.5% are having rectal sparing at the time of diagnosis. That's gross, not microscopic. The rectum is involved at the microscopic level in almost all of those cases. There can be macroscopic patchiness, so sometimes if we see a little skip area, we may be inclined to call that Crohn's. But again, at the microscopic level, so I would encourage you, when you see those macroscopic patch areas, take a biopsy there and see if there's microscopic patchiness or not, because that's much more important than macroscopic patchiness. The so-called cecal stripe or periappendiceal inflammation, so you have left-sided disease and then it all looks good and you have a little bit of inflammation periappendiceal, that is still ulcerative colitis. And the other important piece of data that's emerged is we're all in the practice of scoping upper and lower when we diagnose our kids with inflammatory bowel disease at the time of diagnosis, but we do see microscopic gastritis in the majority, more than 50% of the patients, and we'll even see non-specific macroscopic gastritis in about a third of the patients, or 25% of the patients at the time of diagnosis. So seeing some change in the stomach doesn't make you necessarily Crohn's disease. And I would highlight the paper that Athos was the first author on through NASPGHAN, looking at guidelines in diagnosing and phenotyping inflammatory bowel disease, because this is an excellent vindication and collaboration of what he put out in that paper. So this is the best minds got together and came up with what is the best way to treat ulcerative colitis today. And I apologize that it's a very busy slide, but I want to highlight, and I can't do it because I don't have a pointer that goes to either screen, but what I want to highlight is if you just look at the diagnosis of ulcerative colitis, and if we use PUCAI score to divide mild and then moderate to severe and severe fulminant, if you look at this, at the extremes of this disease spectrum, so the mild would be induced with mesalamine. If they respond, great. If not, they could get a round of steroids to induce remission and then go on to a mesalamine product, in this case, Pentasa. For the moderates, they would be induced with oral steroids. If they respond, go on to mesalamine, and if not, second-line therapy such as a calcineurin inhibitor or anti-TNF. And for the severes, the concept was they would all be hospitalized, IV steroids, and we're going to even talk about a severe case later today, and then go on, if they don't respond to second-line therapy, either calcineurin, anti-TNF, or surgery. And if they do respond, they go to oral steroids and ultimately, hopefully, mesalamine products. So did the enrolling physicians actually follow the protocol? So in 2% of the cases, severe patients were started on Pentasa, and in 2% of the so-called mild patients, they were actually hospitalized for IV steroids. So those are your outliers, but it's interesting to see. Now, is that because the PUCAI isn't as good as we think, and the physician, by global assessment, felt differently about the patient? Is that because not everyone reads a protocol, or is that because there's still variation of practice? There's a lot of different ways to interpret it, but it is interesting to see that even today, where we thought we could risk stratify our patients by PUCAI, we are doing different things. In fact, where all those patients who were severe we thought would go in-house for IV steroids, more than 25% were actually placed on oral steroids. So the concept of risk stratification is certainly excellent, and we're trying to employ it in the PROTECT study. But like any great thought, how you actually put it into practice is still something we all need to talk about and work on. What about Crohn's disease in the last 120 seconds that I have? If we think about it, we all recognize that there are different progressions of disease. We have those patients who just seem to have a little bit of inflammation percolate along and never have a complication. We have those who seem to progress over many months to years to stricturing and internally penetrating disease. We have those who seem to fall like a lead balloon into complications. And this is really breaking out who is which ones of these patients is what the RISK project was designed to do. Until then, we do have some consensus and some gestalt of who are going to be the bad actors. If at the time that I scope you have deep ulcerations, you're already trying to go transmural. That's what you're telling me. And those are probably patients who are going to have long-term complicated disease. If you have ongoing needs for steroids, ongoing growth failure and bad bones, or severe perianal disease, you're probably going to be a bad actor. And so that gets us to the idea, if we're going to optimize our therapies, let's talk about treating to target. And we've talked about it yesterday. I'm sure we'll talk about it more in the cases today. You can almost say, start with whatever you want, but give yourself and your patient and family realistic timelines, realistic goalposts of how long it's going to take for this to work, how you're going to reassess, and if it works, great, and if not, you're going to move on. Don't make the mistake of locking into a therapy long term if it's not working. And the use of fecal markers such as calprotectin, repeat endoscopy and repeat imaging and blood work, physical exam, and most importantly in kids who are Tanner 2-3 growth are all the biomarkers and imaging that we have at our disposal to make sure we're doing the right thing for our patients. If it ain't working, then you got to move on and adjust your therapy, and whatever therapy you pick, make sure you've optimized it. And this type of treatment to target has been shown to work in other disease states which are listed there. Athos already took us through the idea of loss of response, and for me, I still would talk about GI symptoms on therapy. And so if you have your patient on a biologic and they're having symptoms, you need to evaluate why that is. And a lot of this you've already talked about, Athos, so I'm going to skip through. We recognize the ways of making biologic therapy durable. Athos also showed a Smar-Dubinsky study. There was another study from Ann Griffith's group and Cynthia Papoulis at this meeting, actually looking slightly earlier before that first maintenance dose. Very intriguing idea to see if I pick a maintenance dose of your biologic, do I have adequate levels, and is it going to give you good long-term dosing at that level? We talk about mucosal healing as an endpoint. This is just one proof of concept that was done at UC San Diego by Bill Sanborn's group, where he did show if I scope you enough and I play with your drug levels, I can get you to mucosal healing. But the one thing in this paper I would highlight, the 67 Crohn's disease patients had 161 endoscopies to assure this mucosal healing. I don't know about you, I'm exhausted just thinking about trying to get that done. And do we have the resources and the finances to make that happen? So it's a great proof of concept. We need to have a discussion how we're actually going to implement this. So, ladies and gentlemen, in summary, hopefully I have impressed upon all of us that we are actually talking about inflammatory bowel diseases, and that it's a family of diseases. It's not just two diseases. Most importantly, we need to accurately diagnose, phenotype, and stage our patients from day one. And once we do that, we're going to toss out the pyramid and go to a personalized approach, risk stratify our patients, pick a target and treat to it, and optimize the therapy. And in doing so, if we treat the whole patient, we'll get our best results. Thank you.